education for almost nothing. And for that, I'm eternally grateful. So it's always a great honor to speak to colleagues in India. And we've all been worried about the news we are hearing about the COVID, and I hope all of you are staying healthy and your families are well. I'm delighted to speak about a topic about which I've thought about for most of my grown-up years, the effects of testosterone on muscle and bone. Here are my conflicts. In particular, I'm not here to speak on behalf of American Board of Internal Medicine or the Endocrine Society or the institutions with which I am affiliated. In my presentation, I'll review the findings of recent large randomized trials on the effects of testosterone replacement therapy on muscle and bone in men. I'll also share with you some of the data from our studies of the mechanisms of testosterone's anabolic effects and the strategies that we can use to achieve higher tissue selectivity and improve the benefit to risk ratio. I'll then make an attempt to synthesize this information and share with you my personal perspective of the field. The idea that testosterone has anabolic effects on the muscle isn't new. Humans have known since antiquity that you can take away the vigor of men by removing the testes. And amongst cannibal tribes, it was not an uncommon practice to castrate the men prior to the sacrificial feast. The sex differences in the muscle mass between boys and girls at puberty are also due to much greater testosterone concentrations in men. Prior to puberty, boys and girls have the same lean mass. But at the end of the puberty, due to the combined effects of testosterone and growth hormone, boys end up with 4 to 5 kilogram greater muscle mass and substantially greater muscle strength than girls. A large number of epidemiologic studies are in agreement that circulating testosterone levels are associated with skeletal muscle mass, muscle strength, self-reported as well as performance-based measures of physical function, mobility limitation. Also, I think the most persuasive evidence has emerged from the empirical use of anabolic steroids by athletes. And there's a large amount of anecdotal information that anabolic steroids increase muscle mass, strength, and performance in effort-dependent measures of muscle strength and power. But in the scientific community, surprisingly, until the early 1990s, there was huge amount of controversy around the anabolic effects of testosterone. In fact, in 1988, the Endocrine Society had a position statement that there's no evidence that androgenic anabolic steroids increase muscle mass or strength in normal men. And the prevalent thought at the time was that these effects were largely psychological, that testosterone promoted aggressive behavior, and therefore men using large doses of testosterone or other anabolic steroids performed better in effort-dependent measures of muscle strength and power. And the clinical trials data was also very murky and very inconclusive. Half the trials showed some benefit in muscle mass and strength, and the other half of the studies did not show any benefit. So why was this issue so controversial? To be sure, many of the trials done prior to 1990s were not randomized or placebo-controlled. Some of the studies included competitive athletes whose desire to win at any cost precluded their adherence to the study protocols rigorously. Also, the athletes use very large doses of steroids and often multiple steroids, while in controlled clinical studies, for ethical reasons, the doses used were relatively small. In fact, the highest dose that had been used was 100 milligram of testosterone enanthate, a replacement dose. Similarly, most of the studies did not control exercise intensity, or protein or energy intake, and that was a major confounding factor. So early in my career, I established a collaboration with two really outstanding exercise physiologists, Tom Storer and Rich Casaburi, who've been my friends and collaborators for the past almost 30 years. We uh, conducted this trial. This was a randomized controlled trial in which we used a clearly supraphysiologic dose of testosterone. At 600 milligram of testosterone in anthid, the dose was 6 times the replacement dose. We controlled the exercise stimulus as well as protein and energy intake at the outset. The intervention duration was 10 weeks, and we looked at the effects of testosterone alone and in combination with a resistance exercise training. So testosterone treatment was associated with substantially greater gains in fat-free mass, shown here, and maximal voluntary strength, not shown in this slide. And the effects of testosterone plus exercise were greater than either intervention alone. So this study clearly changed the academic view and established unequivocally that androgens have anabolic effects. Subsequent studies in hypogonadal men by our group, shown here, and by many other investigators, showed that in hypogonadal men, replacement doses of testosterone increase muscle mass and strength. The anabolic effects of testosterone on muscle mass and muscle strength are related to testosterone dose and circulating testosterone concentrations. So in this randomized trial, we recruited healthy young and healthy older men and suppressed their endogenous testosterone production by administering a long-acting GnRH analog. We then administered graded doses of testosterone in anthid ranging from subphysiologic, 25 milligram per week, to clearly supraphysiologic, 300 and 600 milligram per week. You can see that testosterone administration was associated with the dose-dependent increments in leg press strength, shown here, and fat-free mass that is not shown in this slide. Since then, especially over the last 10 years, a number of well-conducted randomized trials have been published. Two of the largest trials I'll discuss in some detail, the T trials and the T4DM trial, which was published just in the last a couple of months. The T trials were funded by National Institute on Aging, and T4DM trial was funded by the Australian MRC and was conducted at Australian sites. In this particular study, the TEAM trial, we determined the effects of a replacement dose of testosterone in older men with low or low normal testosterone concentrations. These were community dwelling, relatively healthy older men. Testosterone with greater gains in lean body mass, leg press strength and power, and stair climbing speed and power. Testosterone treatment was also associated with greater gains in VO2 peak, a measure of endurance, and peak work rate. And the changes in VO2 peak were related to increases in hemoglobin induced by testosterone treatment. In TOM trial, we recruited mobility limited older men who had multiple comorbid conditions. This was a randomized placebo-controlled trial in which men were randomized to testosterone or a placebo gel. Testosterone treatment was associated with a greater proportion of men improving their leg press strength, chest press strength, as well as stair climbing power more than placebo. The testosterone trials were a set of 7 placebo-controlled, double-blind, coordinated trials. The 3 primary trials were the sexual function, physical function, and vitality trials. The participants in the T trials were community-dwelling older men, 65 years or older, who had an average of 2 fasting early morning total testosterone levels less than 275 nanogram per deciliter by LCMS-MS, plus one of 3 set of symptoms, either sexual dysfunction or mobility limitation or fatigue. These men were randomized to testosterone or placebo, and the circulating levels of testosterone were adjusted to maintain on-treatment testosterone levels between 400 and 700 nanogram per deciliter. In these mobility-limited older hypogonadal men, testosterone treatment consistently improved self-reported walking ability and modestly improved 6-minute walking distance. But the improvements in gait speed were small, but they were related to the increments in testosterone levels. In other studies, we have shown that testosterone treatment improves fat-free mass, muscle strength in men with chronic obstructive lung disease, as well as in HIV-infected men who are experiencing weight loss. And the effects of testosterone on fat-free mass, as well as muscle strength, are augmented by resistance exercise training. So the randomized trials are in agreement that testosterone administration increases muscle mass and strength. These effects are dose-related. At high doses, very substantial skeletal muscle remodeling is possible even in older men. Improvements in walking speed and VO2 peak are modest during replacement doses of testosterone, and the doses that can be administered in clinical setting are limited by concerns about adverse effects, particularly the uncertainty about long-term cardiovascular and prostate safety. So we need strategies to achieve a higher level of tissue selectivity to improve the benefit to risk ratio. And it's possible that the functional, cognitive, and behavioral training may be required to translate muscle mass and strength gains during testosterone treatment into functional improvements. So a great deal of effort, both in pharmaceutical world and in the academia, has been invested in developing strategies to improve the benefit to risk ratio. And in general, 3 strategies have been used in this perspective. One is to use testosterone plus 5-alpha reductase inhibitors to spare the prostate while retaining anabolic effects. Develop tissue-selective androgen receptor modulators, or SARMs. And at a post-receptor level, understand the mechanisms of testosterone action and find signaling molecules, such as follistatin, that are activated by testosterone and that promote myogenesis, but spare the prostate. And I'll show you examples of each one of these strategies. So this is a SARM that was developed initially by Lilly and acquired by Transition Therapeutics. And this study was supported by a grant from National Institute of Aging. In this particular study, we used a prostate-sparing SARM in prostate cancer survivors. And recall that prostate cancer, or history of prostate cancer, is a relative contraindication for testosterone. And our goal here was to see if a prostate-sparing SARM can be administered safely to prostate cancer survivors who have low risk of disease recurrence by virtue of having had radical prostatectomy and undetectable PSA 2 or more years after radical prostatectomy. So in this initial randomized trial, the participants were randomized to one of 4 doses, including a placebo. And you can see that SARM administration was associated with dose-dependent increments in lean mass, total body lean mass, as well as appendicular lean mass, and reductions in whole body and appendicular fat mass. So the SARM was able to exert its anabolic effects, but there were no changes in PSA and no evidence of disease recurrence over this short 12-week period. So this provides proof of concept that one can theoretically develop prostate-sparing selective androgen receptor modulators. The rationale for the combined administration of testosterone plus 5-alpha reductase inhibitors is based on the hypothesis that conversion of testosterone to DHT is not essential for mediating testosterone's anabolic effects on the muscle and bone, but is necessary for mediating its effects on the prostate. So combined administration of testosterone plus 5-alpha reductase inhibitor would increase muscle mass and strength and hopefully bone mass without affecting the prostate. To test this hypothesis, we suppressed the endogenous testosterone production in healthy young men by administering a long-acting GnRH agonist. And these men were then randomized to receive one of these 4 doses of testosterone enanthate weekly for 20 weeks, 50, 125, 300, and 600 milligram. And within each group, they were randomized to receive either dutasteride, a dual 5-alpha reductase inhibitor that blocks both type 1 and type 2 5-alpha reductase enzymes, or placebo. So we thus created 2 groups of men, those in whom the endogenous DHT production was suppressed by dutasteride administration, and these men had very low DHT levels, but different DHT levels in the placebo-treated arm depending on the testosterone dose. And you can see that both groups, those treated with dutasteride or placebo, had similar total testosterone levels that were proportional to the administered testosterone dose. And to summarize, testosterone administration in graded doses was associated with the dose-dependent increases in fat-free mass shown here and maximal voluntary strengths. But there was no difference in men randomized to placebo or dutasteride. And the relationship of changes in testosterone and change in fat-free mass was not different statistically between men randomized to dutasteride or placebo, indicating that 5-alpha reduction of testosterone is not obligatory for mediating its anabolic effects on the muscle. So in adult men, DHT is not essential for mediating its effects on muscle, sexual function, erythropoiesis, or bone markers. And I didn't show you these data because of time. However, when testosterone levels are low, intraprostatic DHT may become important in amplifying testosterone effect on the prostate growth. But this study provides proof of concept that you can administer testosterone with 5-alpha reductase inhibitor and preserve its anabolic effects while sparing the prostate. So how does testosterone exert its anabolic effects on the muscle? Our studies have shown that testosterone induces muscle fiber hypertrophy. It increases the cross-sectional area of both type 1 and type 2 fibers. It increases the number of muscle progenitor cells called the satellite cells. But it doesn't change the number of muscle fibers or the relative proportion of type 1 or type 2 fibers. So how does testosterone increase the number of muscle progenitor cells? Our studies have shown that testosterone promotes the differentiation of muscle progenitor cells into the myogenic lineage and inhibits their differentiation into the adipogenic lineage. And it does so by activating the Wnt signaling pathway. So like testosterone binds to its cognate receptor, the androgen receptor, and liganded androgen receptor changes its conformation and recruits a number of coactivators, including beta-catenin and other co-activators, and this assembly then translocates into the nucleus where it binds transcription factor TCF4 and activates a number of Wnt target genes, including follistatin. And thus it promotes differentiation of these progenitor cells into the myogenic lineage and inhibits their differentiation into a adipogenic lineage. And our studies that were led by colleague Rajan Singh show that follistatin, which is activated by testosterone, is a critical mediator. Blocking follistatin blocks testosterone's effects on myogenic differentiation. So we were very excited about this finding that follistatin mediates the anabolic effects of testosterone. So we administered recombinant follistatin to wild-type mice. And you can see that follistatin also is very anabolic. You can see increase in muscle mass, and it's also very lipolytic. So it does the same things that testosterone does as expected. But surprisingly, follistatin administration completely spared the prostate. So we were very interested in finding out why follistatin, which mediates testosterone's effects, exerted anabolic effects on the muscle, but spared the prostate. And differential gene expression studies and RNA-seq analysis showed implicated ODC1, ornithine decarboxylase 1, as the critical gene which is activated by testosterone in the prostate, but is not affected by follistatin. So we then administered testosterone with and without ODC1 inhibitor. So our hypothesis was that since ODC1 mediates testosterone's effects on the prostate and is not affected by follistatin, if we gave a blocker of ODC1 with testosterone, it should block its effects on the prostate, but not on the muscle. And that's exactly what we found. In castrated mice, levator mass was reduced as expected, and testosterone replacement of castrated mice restored levator mass. But DFMO, which is a blocker of ODC1, had no effect on levator mass, while DFMO blocked testosterone effects on the prostate. So ODC1 inhibitor, when given with testosterone, can retain the anabolic effects while blocking its prostate effects. And our studies, ongoing studies, suggest that the differential effects of testosterone on muscle and the prostate when we give an ODC1 inhibitor is because testosterone additionally affects the one carbon pathway through methionine, which provides the substrate for polyamine biosynthesis, while in the prostate, testosterone spares this S-adenosyl methionine decarboxylase enzyme. So there is tissue-specific regulation of this critical enzyme so that in the muscle, DFMO effects on polyamine are not exerted because of this salvage pathway. So in summary, testosterone increases muscle mass, strength, and self-reported and performance-based function. Effects on muscle mass and strength are dose-related. The translation of muscle mass and strength gains into clinically meaningful improvements in health outcomes, disability, fractures, health-related quality of life, may require adjunctive, functional, cognitive, as well as exercise training in larger trials of longer duration. What about testosterone effects on the bone? Testosterone exerts direct and indirect effects on bone formation and resorption. And a lot of the work that I'm going to show you has been done in the lab of Sandeep Khosla at Mayo Clinic, Joel Finkelstein at Mass General Hospital at Harvard Medical School, and many other colleagues. Testosterone exerts direct effects that are both mediated through androgen receptor, as well as indirectly through the estrogen receptor alpha through its conversion by aromatase to estradiol. In boys during puberty, testosterone stimulates periosteal apposition, increasing bone width through classical androgen receptor signaling. It also directly affects osteoblastic bone formation through a variety of mechanisms. Its indirect effects through estradiol are mediated through estradiol's effects in inhibiting bone remodeling, likely via effects on osteocytes or osteoblasts. Estrogens also inhibit bone resorption by direct effects on osteoclasts, as well as through its effects on T cell regulation of osteoclasts. But there may also be estrogen effects directly on the osteoblasts. Testosterone may also have additional effects on the bone indirectly through increase in muscle mass and strength, which may reduce fall propensity. Mendelian randomization studies also have shown that a number of loci associated with testosterone levels, as well as estradiol levels, a number of SNPs in the aromatase gene are associated with bone mineral density. Mutations in estrogen receptor alpha, as well as in the aromatase gene, have been associated with delayed epiphyseal fusion and with osteoporosis in men. Elegant studies done by Sandeep Khosla and colleagues and Joel Finkelstein and colleagues have shown the important role of both testosterone itself as an androgen and of estradiol derived from testosterone in mediating testosterone effects on the bone. In children prior to puberty, testosterone predominantly increases cortical bone and bone apposition, which results in thicker bones. And the effects on trabecular bone also occur, but are of lesser magnitude than on the cortical bone. In adult hypogonadal men, testosterone has greater effects on vertebral bone mineral density, which is predominantly trabecular bone. And after many years of testosterone replacement, the bone density may approach normal in hypogonadal men. Two large recent trials have looked at the effect of testosterone replacement in older men. In the T trial, we examined the effects of testosterone replacement in older men with unequivocally low testosterone levels. In both the spine and the hip, testosterone administration improved areal as well as volumetric bone density and estimated bone strength. Improvements in volumetric bone density and estimated bone strength were greater in trabecular than in the peripheral bone. A recent trial done in Australia, the T4 bone trial, which was a sub-study of the T2DM trial, which was primarily a diabetes prevention trial, used HRPQ-CT to determine the effects of testosterone on bone architecture and volumetric bone density of the tibia and radius. And testosterone treatment was associated with greater improvements in cortical bone density as well as trabecular bone density. But unlike the T trial, the T4 bone trial found greater improvements in cortical bone density. And I'm not sure what the reasons for the differences in findings are between the T4 bone trial and the T trial, but one important difference could be the method. We used PQCT in the T trials, while the Australian colleagues used HRPQCT and looked at different sets of bones. Also, the men in T4 bone trial were not hypogonadal, while the men in the T trials were indeed hypogonadal. So in summary, testosterone increases vertebral and femoral areal as well as volumetric bone density and bone strength in hypogonadal men, as well as in older men with low testosterone levels. Effects on bone fractures remain unknown because none of the trials conducted today have been long enough or large enough to determine effects on clinically meaningful fractures. Fortunately, there's an ongoing randomized trial called the TRAVERSE trial, which is a cardiovascular safety trial that is ongoing. That'll enroll 6,000 hypogonadal men in the US at 400 different trial sites, and will also determine the effects on clinical bone fractures. So TRAVERSE trial, which will enroll men for up to 5 years, will teach us a lot about the cardiovascular safety, but also about prostate safety, bone fractures, depression, progression to diabetes, and a whole lot of other clinically important outcomes.